If you look at the biopsy, you can easily make a diagnosis. You are seeing the classic Reed-Steinberg cells at multiple places. So this is a case of Hodgkin lymphoma. There is no doubt about that. The only thing that's confusing here is they have given history of HIV. Remember, in the setting of HIV, DLBCL, that is diffuse large B-cell lymphoma, is more common. But it doesn't mean that you cannot get Hodgkin lymphoma. You can get Hodgkin lymphoma in the background of HIV also. And you're seeing a rubbery, non-tender lymph nodes in the neck and the axilla, which is so characteristic of Hodgkin lymphoma. So where the nodes are going to have the typical India rubber consistency, and patients might have these symptoms like fever, weight loss, night sweats, and so on. And almost like 15 to 20% of patients with Hodgkin lymphoma tend to have pruritus. That's quite common. 15 to 20% patients with Hodgkin lymphoma can have pruritus. And patients having a slight reduction in hemoglobin, and there's a bit of increase in eosinophils also, which can be seen in Hodgkin lymphoma. I cannot diagnose myeloid leukemia using a lymph node biopsy because you need bone marrow for that. Plus, I would say that myeloid leukemias usually do not present with lymphadenopathy. Lymphoid leukemias, yes. But myeloid leukemia is very rarely present with your lymphadenopathy. CML can present with massive splenomegaly, but lymphadenopathy, again, I would not say it's a characteristic feature of myeloid leukemia. And multiple myeloma is a plasma cell neoplasm. And I don't think you can diagnose in such a young patient. Usually happens after 40-50 years. It's a disease of old people. Plus, you have to have evidence of malignant plasma cells, and there is no craft features to diagnose multiple myeloma here. So I'm going to ignore that option.